Hit the subscribe button or visit us at auau.auanet.org.
Thank you, Dr. Stratton. In the interest of time, I'm going to try to get us back a little bit so we'll have more time for the breakout session. I'm going to talk today on non-metastatic CRPC, and all of the information I'm going to present is in your handout. So if I go a little bit fast forward, don't worry, because they'll also be covered in our breakout session. Waiting for the slide to advance here. Dr. Borjan has well covered the natural history of biochemical recurrence. And so in this session, we're going to be covering those patients who are biochemically recurrent on ADT therapy. We've already set the stage for the biochemical recurrence background. I know that there's over almost 35,000 deaths a year in the United States, and one of the pathways to lethality is developing that androgen-resistant state, castration resistance, and sort of a way to that arrival is for patients who are on androgen deprivation therapy to progress even despite the absence of disease on conventional imaging. Why do we focus on this, and why was this so important? Well, first of all, if it's circulating tumor cells or very low volume metastatic disease, our opportunity for eradicating the disease, putting it into an additional state of prolonged remission is certainly there. And we've seen, and you'll see throughout the course of these presentations, that therapies that are effective in late stage castration resistance seem to be even more effective moved up earlier in the disease state. And examples of these include use of enzalutamide, originally post-chemo CRPC, then pre-chemo CRPC, and now, of course, metastatic hormone-sensitive disease. The use of docetaxel in the castration-resistant, 3 months benefit, looking at a year benefit in the metastatic state. So the other thing that was realized is delaying the development of metastases is a clinically relevant, certainly to the patients, and if it can be associated with improving survival, then that window of opportunity is there, but it may close quickly. We all know that there's been an explosion of new therapies and novel second-generation anti-androgens, enzalutamide, apalutamide, and darolutamide, all with these three objectives: preventing androgen binding at the receptor level, inhibiting translocation into the nucleus, and interfering with binding of the androgen receptor to DNA. That was one of those pre-questions, but those are the three ways in which these are probably tenfold more powerful than the first generation anti-androgens. Data derived from previous bone strengthening studies demonstrated when patients didn't have metastases but were followed that PSA doubling time was a predictor of the development of metastatic disease, and somewhere in that range of less than 12, less than 10 months is where we really see the doubling times take impact. So the guidelines, Dr. Stratton alluded to this earlier in terms of following these patients, and it's recommended even if you're not treating them to do serial PSA monitoring and interval periodic imaging in 6 to 12 months. So that's changing with the use of these novel PET scans, and certainly they're being applied in the M0 state, but somewhere in that 6 to 12 month period, even when the PSAs are relatively low, it's reasonable to reassess for that. What do the guidelines say? That we should offer apalutamide, darolutamide, or enzalutamide with continued ADT in those patients with non-metastatic disease at high risk for developing the metastatic sites. And those are defined, as you'll see in the trials, as patients with PSA doubling times of less than or equal to 10 months. Observation is still very reasonable for those patients with slow doubling times at lower risk for the development of metastatic disease. And then in the absence of a clinical trial, there's really not a role for chemotherapy or immunotherapy in these particular patients. I'll skip through this just to say that there was a period of time when we had no therapies in this space. And that's when the FDA and the Oncology Drug Advisory stepped in and said, we need to study this. And they came up with the concept of metastasis-free survival, which is the endpoint in which these drugs receive their approval. The good news for you is that the studies were designed very similarly. So we'll go through the 3 studies, but the Spartan study looked at apalutamide as compared to placebo in patients with this non-metastatic CRPC, again, enriching it with those patients at risk, doubling times of less than 10 months, with a primary endpoint of metastasis-free survival. The patients on average had doubling times of about 4.5 months. This was the primary endpoint shown on these Kaplan-Meier curves, but it was equivalent of about greater than 20 months of metastasis-free survival or death, which was included in the endpoint benefit, with a very significant p-value and a high ratio there. The adverse events are, of course, noted in your handout as well, and there are fatigue and hypertension. Unique to this was the development of rash. And so these rashes were self-limited by discontinuing and then reinstituting the therapy, but there was noted to be a small percentage of patients that had rash. And then also unique to apalutamide was the development of hypothyroidism in a small percentage of those patients. So we usually recommend getting baseline thyroid function tests and monitoring those periodically. This was, again, the 40 months of metastasis-free survival benefit as compared to 16 in the placebo. And then, of course, these are non-metastatic patients, so most have very little symptoms other than their primary ADT. And this quality of life study showed that we really weren't impacting their quality of life negatively. So that's an important concept. And then with longer follow-up, overall survival by about a year was demonstrated by early institution of therapy. The Aramaic Study was very similar in design, looked at the use of darolutamide, and again, patients with rapid doubling times, comparing the active drug to placebo with a primary endpoint of metastasis-free survival. Again, very similar characteristics to what you'd enroll in your patient population, and again, a very less than 5 on the median PSA doubling time for these patients. A very similar Kaplan-Meier curve, so we're seeing consistency with the class of medications being used here, and highly significant benefit in terms of metastasis-free survival benefit. Side effect profiles, again, very similar for the class, but very well tolerated. And again, just seeing mostly side effects that you would expect related to that androgen deprivation state. This, again, was a quality of life study that showed that there was some clinically significant delay in the deterioration when it came to bowel and urinary symptoms as compared to placebo. So no worsening of their quality of life, but perhaps improvement in delaying some of these side effects. Again, about 2 years of benefit in terms of prevention or delaying metastasis-free survival or death, and with longer follow-up, an overall survival benefit as demonstrated here by more than a year. I'm going to go lastly to the PROSPER trial, used enzalutamide, very similar clinical trial design, enriched with those patients with rapid PSA doubling. Again, looking at that what was at the time a new clinical endpoint of metastasis-free survival. The doubling times were similarly very rapid, and the benefit was similar in terms of very good, highly significant metastasis-free survival for those patients with enzalutamide as compared to the placebo. Again, well tolerated. For example, I think it was around 3% or some less than 5% of patients having to discontinue medication due to these adverse events, and those are also listed in your handouts. Again, the quality of life information suggested that patients were stable or improved, and so we weren't harming them with institution of this therapy. The metastasis-free survival curves are probably looking very similar to you now that I've shown you all 3 studies, but again, highly significant improvement in delaying metastases and or death. And with longer follow-up, again, an additional at least 1 year or more for these patients with institution of early therapy. So in summary, patient selection for these patients is important, and clinicians should offer apalutamide, darolutamide, or enzalutamide with continued ADT in these high-risk patients. These are selected out for PSA doubling times of less than 10 months, and it may be reasonable to observe patients with slower doubling times. Their quality of life is maintained, and these are all FDA approved based on metastasis-free survival, and we now know that in addition to that, there is overall survival. So with that, I think I'm going to hand it back over to the AUA headquarters for us to be able to begin to work into our breakout sessions. Thank you very much.